Morning, good afternoon, good day, and good night, depending on whichever part of the world you're from. It's always such a pleasure coming into your homes. I am Sylvia Litana Robertson. How's everybody doing? And how's COVID treating each and every one of you? I'm sure most of us have been COVID to death right about now, right? Well, we're coming to the end of our month, and at the end of every month, we always have a medical topic that we bring forth. And of course, this medical topic or topics are always accompanied by the experts or the powers that might be that will be able to deliberate, break it down, and explain to us exactly what we are about to share with you. Today's topic is about endometriosis and uterine fibroids. Tongue twister, isn't it? I was just telling our chair lady a few seconds ago that some of these terminologies I tell you are above my pay grade. I just can't. I have to read as I'm speaking to you, because if I try to say it by myself, it's all going to come out right. Nonetheless, today we have a special guest who is going to be introduced by our chairperson. And of course, as always, Ambassador Lisa, welcome. Nia Song, welcome. And our special guest, welcome until you're formally introduced. And of course, Madam Chair, welcome. Thank you very much for all of you for tuning in. Go to our Facebook as well. We are live on Facebook. And if you want to chime in and call us, please do so. This is your program. We are here for you. We are here to discuss topics that affect you and I. It's not always about those on the panel. It's about you, the viewers at home. Is there something you want us to talk about? Is there a topic you want us to repeat, or is there a topic you would like to go over again? With that being said, let me welcome our host, Mr. Nielsen. Come on down.
Good afternoon. Thank you, thank you, thank you. And it is another day. Yes, it is another rendezvous for the Africa Online Media Corporation. And I see Dr. Ogorje zooming in there from the far northwest of the United States. So it is Sunday, March 28th. That is the year 2021. It is the 87th day of 2021. There are 278 days until the year ends. Well, start preparing. It's never too late or too early. It is the 13th Sunday of 2021, if you mind counting up with me, because there will be 352 Sundays. So we have 13th today. So let's see how far we go. We have 9 days of spring so far. Spring started, no, not spring. 9 days of, what is it? Yes, spring. Okay, it's 9 days of spring. Yes, that means that we still have 85 days before we see summer. So for those of you in the South, it will get hot and hotter, and the hottest, August, July, August, those are the months when it is hottest. But those in Delaware, the first state, well, they'll be first to embrace the cherry blossoms and the other beauties that come with spring. While we wait for all that to happen, what has history to teach us on this day? Well, just one major thing. On this day in 2009, the first cases of the H1N1 swine flu in the United States were reported in, guess where? 2 people in the state of California. It has the most people, but it is not the largest state. Alaska is. But that is not our primary concern this Sunday. What concerns us is the awareness that the month of March, that ends on Wednesday coming, has been Women's History Month. They didn't even mention it, but it has been Women's History Month. At times celebrating the contributions women have made towards the building of a more perfect union in this land that stretches from shining sea to shining sea, the land of the free and home of the brave. It has been a month quietly recognizing the specific achievements that women have made over the course of American history in a variety of fields. The month of March now ends with a look by Africa Online Media Corporation at some ailments that we little know about, ailments that have been very present in the private lives of many of our women folk. What further concerns us this Sunday is that most of our women have known and quietly lived with these ailments without actually crying in public, but crying in their bedrooms, crying in their hearts. They are endometriosis, forgive my pronunciation, and uterine fibroids. What are these two ailments? How do they present themselves? And what is known about them? I will not attempt to tell you that I know anything about, because until the chair proposed that topic last Sunday, I did not even know the word endometriosis, whatever it is. As we begin today's Africa Online Media Corporation's discussion, therefore, one of my favorite authors, Leo Buscaglia, dangled this quote in front of my mind's eyes. Too often, we underestimate the power of a touch, a smile, a kind word, a listening ear, an honest compliment, or the smallest act of caring, all of which have the potential to turn a life around. End of that quote. I quickly went for the bait because after searching for those ailments in the lives of our women folk, I realized that our attitude towards what we sometimes refer to as the weaker sex, that is in quotes, can sometimes aggravate a situation, block action, endanger a life, or completely postpone the life that Eve's daughters, forgive that term, are meant to live. And call them by their names, we must say endometriosis and uterine fibroids, two nightmares in the lives of some of our women. March, as we already said, has been the month of the woman. As we wrap up that month with a topic akin to women, our immediate concern is to state that endometriosis and uterine fibroids are not totally new. Women have suffered from them for a long, long time, but they seem to be taking a greater toll these days than ever before. And so the question is, why? Despite scientific advances in medicinal breakthroughs, why does endometriosis and uterine fibroids, why do these two remain some of the worst nightmares in many women's lives? Is it that research is not aggressive enough in these areas, or just that along the way, something went wrong? How are endometriosis and uterine fibroids similar, and how are they different? I dare not propose any idea on that. So we invite you to weigh in. We invite you to tell us what you know about these two ailments so quietly taking a toll on our women folk. Have a personal story to tell? Maybe you do. Know someone that has suffered from these? Maybe. Well, tell your story. Endometriosis and uterine fibroids. Tell us what you know about them. A quote I came across but cannot immediately attribute to anyone I know tells me, quote, "No one escapes pain, fear, and suffering. Yet from pain can come wisdom. From fear can come courage. From suffering can come strength, if we have the virtue of resilience." End of quote. With that in mind, let us invite our medical experts to join the conversation and shed that light we all need to be able to raise awareness on the topic. So, whatever we know about endometriosis and the uterine fibroids should bring us around to sow the seed of resilience in our women. We must know that pain, in whatever form, is something we must not allow to be part of any of us, man or woman. We must encourage our men and women alike, men and women of science in particular, to intensify the research and provide us with such outcomes as will bring hope and implant confidence in any and all women who happen to be the unwilling victims of endometriosis and uterine fibroids. I like to pronounce those words repeatedly so they stick in my mind. So when I see a woman twitching and rolling on the floor, I tell her, look, run to the doctor or run to your gynecologist to tell you what is going on. So let Africa Online's chairperson take the chair, as she always does. She never runs away from them, and introduce the discussion by introducing our guests on this program this Sunday afternoon. Over to you, Reverend Pam.
Thank you so much, Nia-Song. You know, I'm so proud of you. I'm really proud of you. You actually said it right, endometriosis and uterine fibroids. Thank you so much. Oh, you've graduated from last week to this week. You can sound like Shay Brown. who visited Harvard and told the mother he went to Harvard. Bottom line is he went. So bottom line is, you know, you can pronounce the names. So thank you so much. Just a point of correction before I welcome our speakers. They are not guests. You know, Dr. Adeline Nkuna is our point physician. She's been our point physician since at the end of 2017. And Dr. Kingsley Ogorje is our chief medical advisor. He's been that since 2018. So they are not guests. They are part of this show, an integral part of this show, but our main speakers today. And I am so excited because this is the first time we're having a tag team, a male and a female. So on behalf of Africa Online Media Corporation, I want to welcome our viewers, our participants, but I am so delighted to welcome this, my beloved brother and sister. And for transparency purposes, yes, Dr. Adeline is actually a younger sister of mine. We are direct cousins. So, but Dr. Ogorje is my brother, you know, and I am very, very excited about this show today because our brothers and sisters across the globe will get to hear from one of theirs. They will hear it from a male woman doctor and from a female woman doctor. And I'm hoping that husbands will also watch this show, brothers will watch it, sons will watch it, because let me tell you, these two conditions are very, very painful. I am not just saying this from a medical perspective, I'm saying it from personal experience because I suffered from both of them in the past. Thank God, not anymore. They are not fun. I had to have 3 surgeries for these conditions. So this is something that is very prevalent in our community, and I'm so excited. So I would like to start with my little sister. I want her to introduce herself. She is an MD, PhD. Dr. Ogorje is an MD, and he has a title from UK, which I'm not very familiar with, is MROG. So he will be introducing himself. So Ade, please take a minute and introduce yourself to our viewers, not our panelists, but our viewers. You're very welcome, my dear sister.
Hello, good morning, afternoon, evening, everybody. Like Reverend Pam has said, I am Dr. Adeline Nkuna. I hold an MD and a PhD degree, and I am also a fellow of the American College of Obstetrics and Gynecology. Of course, I'm a practicing OBGYN here in Delaware in the United States. I'm so excited to be here. And also excited that my brother, Dr. Ogorje, is here too with me.
Yes.
I look forward to having a great 1.5 hours with everybody this afternoon.
Thank you, Ade. And just so you know, for those who don't know, Adeline and Niasong are very close, but you see, Niasong has not seen Ade in a while. That's why he actually missed her state. So Ade, you see what happens when you abandon Niasong for so long. But anyway, Dr. Ogorje, you're amazing. You're on the show every week. Take a minute, my beloved brother, and just introduce yourself to our viewers.
Hello, everybody. My name is Dr. Kingsley Ogorje. I am a family medicine. I practice both family medicine and obstetrics. I also fully trained obstetrician both in Nigeria and UK, and I'm a member of the Royal College of Obs and Gynae. So it's MRCOG, the C is missing. Royal College of Obstetrics and Gynecology, UK, and I'm a member of a fellow of American Board of Family Medicine. I do both obstetrics and women health and family medicine in the US.
Thank you so much, Dr. Ogorje. And there have been times when he's been participating in this show in between deliveries. Isn't that something else? You know, so I am really, really excited. You guys would never know how many women you have helped across the globe. And for those men who are married to women with fibroids, or who can't have kids because of fibroids, or who have maybe 1 or 2, please listen to this show and be kinder to your wives. And those mother-in-laws who always get on your daughter-in-law's case for not having kids, I hope you're watching. But anyway, that's a topic for another day. So before I hand over back to the ambassador, Lisa is cracking up. Before I hand back, this show is unscripted. That's what I love about this show. So before I hand back over to Niasong and our beautiful co-host, I would like to hand the mic to Dr. Adeline to just share a few things, and then Dr. Ogorje will go after that, and the anchors can take it from there. Dr. Ade.
Well, again, today we are going to be talking about fibroids, which is also called uterine leiomyoma, and endometriosis, which are two important conditions that women suffer from, as has been belabored in the past few minutes. So before we start, I'm going to do something a little different today that I haven't done on the show before. In order to be able to present these two conditions, I'm going to bring forth two cases. For those people who have pens or pencils, I just like for you to write some of the things that I say down. I will give the basics. I promise you I will not be technical. I'm going to present two patients to us. So we have a 40-year-old female who comes into the office. She reports that she has regular menses and that her menses are every 28 days. She complains, however, that for the past 6 months, her menses have become heavy and that she feels a fullness in her pelvis. She has no pain, and she is also on no contraception. She reports that her first period, which we call menarche, in gynecology term, was at age 9. This lady has had one pregnancy and has one child. She is obese. Her BMI, which is body mass index, I would just say, let's say 31. For the sake of numbers, she doesn't have any other medical problem. So, as Dr. Ogorje will tell you, when a patient presents with a pelvic exam, so the significant part of her exam when I examine her, Dr. Ogorje examines her, is that her uterus is enlarged, irregular in contour, it is firm, has what we call some nodularity, and it is not tender. Okay, patient number 2, we're going to make her 36 years old, also with a 28-day cycle and regular menses. She complains of pain with her menses, and recently it has become intense. This pain is not relieved when she takes ibuprofen. Sometimes in between her periods, she also has some pain. She has pain with intercourse, and she's been trying to conceive unsuccessfully. Her first period was when she was 10 years old. She does not have any medical history. She's not on contraception or any medication. Dr. Ogorje or myself, we check her. We realize her uterus is not really tender. We feel some nodularity across what we call the uterosacral ligaments. Don't worry about that. Dr. Ogorje knows exactly what I'm talking about. And we also feel that when we check the left side of her adnexor, Dr. Ogorje knows that, don't worry about it, she has a little bit of an adnexor mass. So those are two different patients with these two conditions that we're presenting today. So I'm going to give it over to Dr. Ogorje or Nia Song or Sylvia, and we can proceed from there. You can ask your questions.
Okay, thank you, Dr. Adeline. Dr. Ogorje, you want to comment before the anchors take over?
Yeah, I mean, all I would say is that these two conditions are very, very common. They all present with heavy menstrual bleeding and pain, and both are associated with infertility. And there are a few things that are common. They are common in older women. There's some different contrasts, like endometriosis is more common in white women, white fibroid is more common in Black women. I'll stop here and answer specific questions.
Yes, thank you.
Okay, Sylvia.
Okay, Sylvia wants to go first. Go ahead, Sylvia.
That's fine.
Yes. If you had to give me a definition of what endometriosis is versus what for the fibroids are, I'm a layperson and I want to understand the difference. That's number one. Number two, are these are these diseases or sicknesses are people born with them, or do they grow as you grow older?
Okay, so let me start. I'll address the first question, and then maybe Dr. Ogorje can add to what I say. I'll let him address the second question, and I can also add to what he says if there's anything that needs to be added. So let's talk about endometriosis first. Now, the difference between the two is exactly what the disease or the condition is. For endometriosis, before I tell you exactly what it is, I'm going to give a basic anatomy of the uterus, of a woman's uterus. So if you look at a uterus, and if I can just show my hand, you can assume that you know, you can assume that this is the uterus. Just imagine this being the uterus. The uterus has basically three sections, right? The first part of that is the lining of the uterus. Are we together?
Yes.
Immediately beneath the lining is muscle. We call that muscle the myometrium. The lining is called the endometrium. The muscle is called the myometrium. And then the third layer, which is beneath that muscle, right, is called, you have the peritoneum. So what is endometriosis? Generally, in any woman of menstruating age, when they have their cycle, the endometrium is what sheds, and it's called the period. So basically, during a menstrual cycle, the endometrium gets thicker and thicker, waiting for a fertilized egg to be implanted. When that egg is not implanted, certain hormonal changes occur in the body, and the lining then sheds as what we call menses. This is where the endometrium belongs in the uterus. Endometriosis is a condition where this lining, the endometrium, now gets implanted in other parts of the body. Are we together? So they get implanted somewhere in the pelvis, mostly in the pelvis. It can be on the bladder, on the rectum, and it can be in the ovary. So in a nutshell, endometriosis is a condition in which the endometrium, right, in very basic terms, gets implanted in ectopic sites, in sites that are not in the uterus. That's the endometriosis. So let's talk about fibroids. Fibroid actually is a condition of the smooth muscles. So if you remember, we talked about that myometrium, which is the layer underneath the endometrium. So fibroids simply is smooth muscles that in layman's term grows and develops. And because of the effect of estrogen, the fibroid can get bigger and bigger and then begins to grow towards the inner portion of the uterus, or it gets bigger within that wall of the uterus, or it pushes outward toward that peritoneum, which we call the serosa. So the uterine fibroid is actually a smooth muscle condition. So that is the difference between endometriosis and uterine fibroids. Dr. Ogorje.
Yeah, the only thing I want to add is that endometriosis can also affect the uterus itself. When the endometrium is found in the muscle of the uterus, we call that adenomyosis.
That is correct.
Pain.
Yeah.
So, but it's more commonly located in the ovary than other parts that Dr. Adrian has mentioned. So, second question, both conditions are acquired. Although we find endometriosis in women of 8 to 9 years age is very rare, but are all disease of people generally above the age of 25, 30. Fibroid grows with time. Fibroid is actually promoted by estrogen. There are two hormones that control women's growth, estrogen and progesterone. So prolonged exposure to estrogen causes these two conditions to occur. That's why if a woman has not had any baby at all and get to 30 years, most African women with no baby, age of 30, have some fibroid. If a woman starts having a baby at a younger age, chance of developing fibroid is smaller, not exclusive. Same to endometriosis is more common in white women. We don't know why it happens, but there's some theories saying that sometimes if there are different theories, which is more technical, but sometimes they said the what called retrograde menstruation, the menses flow backward and goes to the ovary and cause endometriosis. Sometimes they said the body just changes, a normal cell changes to endometrial cell, we call it transformation or just changes to become an endometriosis. Other times, because of through blood vessel that may leave from the uterine R3 and travel to other parts of the body, we don't know. But both conditions are acquired mostly. It's very uncommon to see them in young people. If a young girl comes to me at 16, I have severe pain when I have a period and miss 3 days of school, it's not endometriosis, very unlikely. If a woman that is 35 has a normal period, and then at 35, period becomes suddenly very painful, that is more likely to be endometriosis.
I see. Thank you. Thank you very much for that clarification. I understand it. Yes, sir?
Yes, I've been wondering, but from the last two speakers already, our special participants, because I did not remember Delaware, I forgot to say that they are our returning members of this house. I kept saying that they were our guests. They are not our guests. They are participants in Africa Online Media Corporation. So one thing that keeps bugging my mind is this thing, as Dr. Ogorje says, acquired. If so, can it then be transmitted sexually or otherwise from person to person? And is it hereditary from mother to daughter?
Well, that's a very good question. Yeah. So first of all, it is not a sexually transmitted illness. So we're going to put that clearly. When Dr. Ogorje refers to it as being acquired, what he's saying, like he mentioned, sometimes it's something as a result of the hormone estrogen. But having said that, uterine fibroids sometimes can have a genetic component to it. So let me take you back to what Dr. Ogorje said. He did mention, estrogen, and he gave a very good scenario of a younger patient versus an older patient. So I'm going to take you back to the scenario that I painted. If you look at the first scenario that I painted, that scenario actually depicts a woman with uterine fibroids. Dr. Ogorje actually touched on the age, and he did talk about exposure to estrogen. So I think we need to talk about some of the risk factors, of uterine fibroids, which is what I'm going to kind of elaborate on. Dr. Ogorje mentioned age, that is correct. So the older we get, the greater, our chances of being diagnosed with developing fibroid and being diagnosed with fibroid. For the reason that Dr. Ogorje pointed out, because we have estrogen stimulation, right? Now, if you look at my example, the patient had her first period at 9. So if you look at having a first period at 9, you're exposed to estrogen stimulation very early on. So that also increases your risk, of developing uterine fibroids. If you get into menopause much later in life, that is increased estrogen exposure over a period of time, which is also another risk factor. So that's one thing that I brought up about the period. Now, if you're obese, I brought that up, generally that can also, or it will contribute to a growth in your fibroid, right? And you ask me why. The reason is because, remember that hormone we keep talking about, the estrogen. When estrogen is produced in the adipose tissue, which is really fatty tissue. So when you're obese, you have an increased production of estrogen in those fatty tissues in the periphery. So that also predisposes you to significant estrogen production. And so you have a tendency to develop that, and also for your fibroid to get bigger and bigger. So we're talking about age, increasing age. We're talking about, estrogen exposure. And then, of course, like Dr. Ogorje pointed out, you see this mostly in people who are like, 20 to 30, mostly 30 to 40 years of age. Dr. Ogorje?
Yeah, I'll also add that if you are slim, you are more likely to develop endometriosis.
Yeah, that's true. I agree. That's true. You're right about that.
We can't win. We can't win.
So this is these two conditions, we don't really know why it happens. We only know the risk factors, so we cannot prevent them. Don't know why it happens. We know if you have 1, 2, 3, 4, you are more likely to develop this or this. Of course, the only thing I would say for both conditions, I don't encourage people to have baby quickly. If you have many children, you start having baby in time, because having both conditions is small. It's very, very small. So that's our idea.
Excellent. Thank you.
And also, just to add, Dr. Ogorje makes a very good point. Having many babies, multi-parity is having a baby young, like you said, but we're not encouraging that. But if somebody's, in a committed relationship and is married, oh, great, you can go ahead and have your babies earlier in your life. The other thing is that what that decreases the incidence of fibroid is contraception. People want, like for instance, birth control pills. They also have a decrease in the incidence of fibroids.
Oh, wonderful. Ambassador Lisa.
Yes, ma'am.
You want to chime in? You have a question or you have a contribution to make to what the esteemed doctors have said?
Yeah, actually, I found something, I'm not sure which one, I think Dr. Adlai Line said that in her second scenario about women having the increased pain with sexual intercourse. I've had 3 children, all natural childbirths. I've given birth to 3 boys, natural childbirth, no endometriosis, no fibers. No, actually I do have, or had one, but it had nothing to do with my childbirth. But my question is, back on the continent, are our girls being trained and taught about these diseases? Or I don't know if they're diseases, but are they being taught about this endometriosis and these fibroids, especially when it comes to the pain that they may be going through when they're in their marital relationships with sexual intercourse?
Well, in answer to your question,
men being taught rather.
Well, I definitely think that there is always room for education when it comes to healthcare, because with education comes preventative healthcare. With education comes an awareness of what anybody is going through with any illness or any condition. Education brings an awareness, especially for these 2 conditions in the men, and also an awareness of the symptoms and the consequences of this condition. I'm going to take you back to scenario 2. Thank you for bringing that up. So this was a 36-year-old woman who came in and complained of pain with her menses that is intense. Now, and that is where the subtle difference between endometriosis and fibroids come in. While fibroids can sometimes, when they get very enlarged, cause pelvic pain, generally they do not until they get to that point. Right? Having said that, but the mechanisms that fibroid will cause pelvic pain. Endometriosis is noted for causing pain, especially pain with your period. And I guess somebody's going to ask me why. So I'm going to go ahead and just tell you why. Because the more we understand, the more it makes sense. We keep talking about this estrogen and progesterone, right? So generally, when the estrogen and the progesterone at the end of a woman's cycle, when they get low, the woman has a period, right? Basically, the lining of your uterus, that endometrium, is responding to these hormonal changes. So you can imagine that if somebody has endometriosis, which is implantation of the endometrium in other sites besides the lining, so those implants are also going to respond during, when you have these hormonal changes going on. So guess what? So not only are you shedding your lining, those other implants are responding. So that is why these women get pain with their period. Now, depending on where the implants are, they could actually have pain with intercourse, and that is a real problem because sometimes it is so painful that these women cannot enjoy sexual relationships with their partner. So it's very important. Normally I tell people that sometimes the symptoms of endometriosis can be, we can really say like I'm not going to the 4 Ds, right? The 4 Ds meaning dysmenorrhea. Don't worry about the big term because I'm going to break it down. Dysmenorrhea being pain with your period. The other one can be dyspareunia, which is pain with intercourse, right? For the reason that I have explained. The third one, well, with dyspareunia is also because of it's very sensitive. When you get those endometrial implants, sometimes the uterus can become hypersensitive. Then we talk about dysuria, which is pain with urination. What has that got to do with your bladder? Because sometimes these implants, when they settle, they also get implanted on the bladder. So guess what? The bladder is not happy, and so they can have pain with urination. In some cases, they can also have pain when they have a bowel movement. We call that dyschezia. So when I think of endometriosis, I think of my 4 big Ds. And it also depends on where these implants, these implants find themselves.
I'm going to go ahead. I was reading a book when I saw this topic and I came across this. She said simply, but frankly, I hurt at places you couldn't imagine at a level beyond your comprehension. If you could feel this pain for just a day, you'd know how strong I am. So the woman, fragile, as we all know, but strong in heart and will, what should they do in circumstances where they begin to experience these things? Before science became popular and we started knowing and talking about these things, girls suffered and maybe cried themselves to sleep every night without ever knowing exactly what was wrong down there. So what should the young girl or the middle-aged woman do when she starts experiencing all these inconveniences?
Dr. Ogorje.
Okay. We are changing to treatment, but I just want to shed more light on what Dr. Glenn just said. The uterus is here, the bladder is here, the rectum is here. So dysmenorrhea is pain with sex affects the uterus. Bladder pain is in front. Sometimes they have blood in their urine. When the endometrial tissue is found inside the bladder, when the uterus is menstruating, the bladder menstruates. I mean, there's a joke that menstruation is frustration of a disappointed uterus. Uterus always want to get pregnant.
Oh my God.
I like that.
So if you disappoint the uterus gets frustrated, you bleed.
Mhm.
So that's menstruation. If you have endometrial tissue on the bladder, you have blood in the urine. You have endometrial tissue in the bowel, you have blood in the poop. The woman comes, I have severe pain on my period, I'm peeing blood, I'm pooping blood. Classical. So what should they do? I'll start with fibroid. Fibroid is easy. Most cases of fibroid you don't have to treat it. If it's not causing any problem, leave it alone. If it's so tiny, leave it alone. Of course, if it becomes huge, it might push on your bladder, causing urinary frequency and pain with passing urine and things like that. Then you need to take it out. If it becomes too big, causing fullness in your pelvic area, it might cause pain with sex, might cause heaviness, causes constipation, you take it out. If it's huge, obstructing the uterine cavity so that the tubes are closed, then it causes infertility, we should take it out. If it's small and it's located just inside the lining of the womb, as she said, there's endometrium, there's muscle, there's serosa. If a fibroid is located inside on the endometrium, beneath the endometrium, it will cause heavy menstrual bleeding and pain. Then you should take it out. If it's not causing any problem, you leave it alone. I've seen African women with fibroid the size of a watermelon, which is pedunculated, means that this is a uterus, a small string of tissue, attach a fibroid there. She gets pregnant, looks like twin because of the fibroid there and the big uterus, and she's going to never have a baby. You don't have to take it out. Take out when it causes problem. Of course, if it has pain with period, the first treatment is we give NSAIDs, ibuprofen or now. If pain becomes severe, then we can consider things like if they don't want, especially if they're located in the inner line of the womb, causes heavy bleeding, we can consider things like birth control pills, sometimes IUD to minimize bleeding. But again, fibroid does not need treatment unless it's causing symptom. And the only treatment, again, depends on the type of, if it's too big, is surgery. I would say, training in Africa, I actually taken out fibroid, this huge woman's tummy. We try to preserve the uterus in the African woman as much as we can. Here in America, the training is simple. Tiny fibroid, doctor recommend hysterectomy because fibroids have been known to regrow. If you are 30-year-old, you have fibroid about the size of the orange, you take it out, by the time you are 50, you might have a fibroid the size of a watermelon. If you want a cure, the uterus needs to go. For an African woman, it's different. They want to keep having baby, or they have no baby. If they have 35, if you take out their womb, they will say no. When they come back, reincarnation. I mean, my people believe that people come back when they die. So if you do what we call hysterectomy in them, they'll be afraid that when they come back in their next world, they won't have a uterus. So those beliefs have to be taken in consideration. That's why we say medicine is, you have to practice what is culturally competent and acceptable medicine. If you're teaching an African woman, try as much as possible to conserve the uterus, while the white woman believes that the life is here. You die, you're gone. you come back as a cat or a dog or a monkey. So they don't care about what part they lose. So that's for fibroids. No treatment if there's no symptom, treatment if it's causing symptoms, hysterectomy for a cure. I'll let my colleague handle the endometriosis.
Right. Yeah. So I agree with Dr. Ogorje with Dr. Ogorje and everything he has said. And thank you so much. You're so entertaining and you're making it so exciting. Thank you very much. But I agree with everything that he has said. Just to add a couple of things about fibroids. Again, sometimes we just treat the symptoms of fibroids. If you remember, patient number 1 had heavy period, right? Heavy menses. Heavy menses was a consequence of the fibroid. So what do we do generally? You treat the symptoms. So we don't do anything to it. We just treat the heavy menses, right? So, and what do we do? So, and the pain. So you can treat them like Dr. Ogorje said with ibuprofen. It belongs to a class that is called NSAIDs. You know, I don't want to say the long name, but the NSAIDs.
Non-steroid anti-inflammatory drugs.
Oh, there you go, big sis. You got it. Go start with that one. So you treat it with NSAIDs. And the reason why Tylenol would not work, the reason why NSAIDs work is because it interferes with the pathophysiological pathway. So you treat heavy period and pain with NSAIDs. You treat heavy period and pain with contraception. So these are some of the things that we use to treat the symptoms of fibroid. You treat them with contraception. That can be oral contraception. It can be what we call an intrauterine device, specifically Mirena. And in very severe cases, there are other things that we can use, like what we call GnRH agonists. But we only use them, agonists when we get to the level. Now, in terms of treatment that is surgical, don't get discouraged. We have mentioned that fibroids can sometimes cause infertility, like Dr. Ogorje just mentioned about it pushing on the fallopian tube. Sometimes the fibroid that is inside the uterus itself can interfere with the implantation. That when the pregnancy comes to implant itself, it can interfere with that. So do not get discouraged because those fibroids can be removed to be able to help with fertility. So the cases where we just take out the fibroid, we call it myomectomy, right? So we just take that out. And sometimes, in some cases, there's also a minimally invasive method of dealing with fibroid. It is called Uterine R3 Embolization. We call it UAE. Now, how does this work? They go through a little artery, they call it the femoral artery by your groin. They put a catheter in there, and they're able to block the blood supply to the uterine artery that supplies the fibroid. So those are some of the conservative way, of treating fibroid. Like Dr. Ogorje said, the answer to fibroid is not always a hysterectomy, but in some cases, the answer is the hysterectomy. So let me take you to the management of people with endometriosis, because Dr. Ogorje gave me the floor to do it. So I'm going to do it. Again, the management is pretty much the same, right? We manage the symptom, because guess what? Endometriosis is a clinical diagnosis. The gold standard is to look with a laparoscopy, diagnostic laparoscopy, but not everybody who comes and presents like patient 2 has to be taken to the operating room to be able to tell. So generally it is diagnosed clinically and we manage the symptom. Again, endometriosis, the number 1 management, again, is an NSAID. So ibuprofen is good. If a young lady has endometriosis, generally that would take care of it. In some cases, when their symptoms are severe and NSAIDs do not work, guess what? We're back to our hormonal management. What are hormonal management? Like with uterine fibroid, we're talking about oral contraception, right? We just talked about that. And it can be any of the, we talked about, contraception, which can be oral or being delivered by other means, either through your uterus or a little ring in your vagina, or progestogen, right? Which is just progestin. Again, in some severe cases, we use the GnRH agonist. Don't worry about that, but the bottom line that it is hormonal. Of course, if that doesn't work, that is when you consider surgery. Surgical management is really reserved for people who have advanced endometriosis, number 1. It is reserved, for people who sometimes have infertility, right? Because endometriosis causes infertility. So sometimes it has to be dealt with. Now, how is this done? It is basically done laparoscopically, where they put a little scope through your belly button, down the side of, down the side of your lower quadrant, the lower part of your belly, and those lesions are actually ablated, right? And sometimes they can do open with local resection. However, in some cases, endometriosis can get really bad. And we're talking about very severe endometriosis. You can end up with a hysterectomy. So the take-home message is that generally, those two conditions are pretty much managed. Management is pretty much approached in the same way for different reasons and for different expected outcome. The key, like with everything in medicine, as Dr. Ogorje knows, is that the care has to be individualized.
Yes.
We'll turn at this time to Reverend Pam in Houston. I know there is a new name on the screen. It's not a new face. It's not a new face. It is a new name, but it is Ade like Adeline, but not Adeline. It's a different person. I'm sure the chair would speak to that.
Okay.
Can I add something about endometriosis?
Of course.
Oh, okay. Go ahead.
Generally, it's a condition whereby some people have very small endometriosis and have the whole pain in the world. Some people have no problem at all. You go to do an appendix, you see the pelvis is full of endometriosis. You say, wow, do you have pain? They say, no. Are you troubled? You say, no. So it's that condition will treat if a patient complains. If I'm doing an appendectomy and I saw the pelvis full of endometriosis, you leave it alone. And as my colleague just said, surgery is mainly indicated when you're looking for infertility or there's a tumor, and we call endometrial tumor in the ovary. So it's a very dynamic thing that we don't really know how to handle it. If the patient complains, we take care of what they complain. What is important for the patient is what we do. Their problem is pain, we'll give you pain medication. Their problem is if you don't have pain, we'll give you birth control if you don't want babies. If you have babies, they will do surgery and we cannot give you birth control if you want babies. Then, of course, what we call medical menopause. We can put it in menopause. Once you go into menopause, both conditions tend to resolve. So if a woman is 42, 43, have endometriosis, have fibroid, not very symptomatic, you say, be patient. The next couple of years, you go into menopause, we don't have to do anything.
Okay, thank you so much, Dr. Ogorje. I would like to acknowledge Dr. Jibade. That Ade is Ade Bisola. Dr. Ade, if you have a question, I will give you the mic before I ask my own questions. Dr. Ade, do you have any questions for our OBGYN doctors?
No, not at all. Thank you.
Oh, okay, thank you so much. I am really proud of both of you. I have quite a few questions, and you guys will decide who takes what, okay? The first one, and Ade, I think the two cases that you presented were because they're in childbearing age, or those are the age range where it's so common. But I have a couple of questions. You guys just bear with me. You guys can select which one, okay? And Ambassador Lisa is very good at writing stuff down. Okay, in my case, I'm not going to go too much into my case, but I want our listeners to know that we are not just doing this. We feel free to share our own experience. I had 3 different surgeries in my case. Most of them were 10 years apart. And when I look back, I wish the first time I had just done the final surgery, because I actually suffered, in between the surgeries. After they took out the fibroids, they came back within 3 years. I was never on birth control pills, never been on it. I don't like taking medications. I'm one of those people that have problems taking medications. I don't know if that could have helped me or prevented it. I did not have any of those predisposing factors. I was like 125 pounds. So, and the truth is, we don't know what happens. But these are my questions. And especially, hopefully, our men will understand when sometimes their wives don't want to have sex, when they have fibroids, because of what our doctors are saying. But why is it that, maybe you guys will say, well, it's because we don't know. Why? First of all, why do the fibroids grow back? Secondly, when would you consider supracervical hysterectomy as opposed to total hysterectomy? 3, why is it that some people are able to have kids, get pregnant when they have the fibroids, and others are not able to? Why? And the last thing is, our meals have anything to do with predisposition to these conditions. So Dr. Ogorje is probably on call. Dr. Ade, you can start with any one of them, and then Dr. Ogorje can, I just, for the record, since I had it, I don't swallow pills, but I took a medication called ketorolac, the injection. The brand name is Toradol. That was the only thing that worked for me. Within 30 minutes, the pains will resolve. But my pains were so horrible. They were just horrible. For a long time, I couldn't even go to work. I had to always get other pharmacists to work for me. So Dr. Ade, if you can address. Yeah.
So I can start off with the first two. There are 4 questions. I can take the first 2, and Dr. Ogorje can add and take the next 2, and we can just go back and forth and add. So the first question was, why do they grow back? No, if you remember the pathophysiology of fibroids, we talk about estrogen, right? Estrogen is what stimulates the fibroid. So yes, they can grow back, because remember, as long as you're of that childbearing age and you have exposure to a lot of estrogen, your fibroid can grow. Yes, they will grow back. So I'll give you an example. If somebody has a myomectomy, which is removal of fibroids, sometimes the fibroids are so tiny, and I'm just going to take us a step back, because you really make a very important point. Why is it that we don't diagnose fibroid in people who are 20 or 23? Have you often wondered? We get to diagnose them when they're in their 30s, in their 40s. Is it because some people don't have fibroid in their 20s? Oh, yes, of course they do. Yes, they do. But guess what? The fibroids are so tiny. When you have that smooth muscle proliferation, it is so tiny that it's of no consequence, right? Remember, we talk about age. As we get older, we're exposed to more estrogen. Remember, as we're getting older, the years are adding up. So guess what? When they get to a certain age, now some of them grow so big, they start causing all these effects that we see, right? So can they grow back? Yes, they can. If I take a patient to the operating room, I take out her fibroid. If she might have 1 or 2 tiny fibroids, then guess what? I'm not going to take out, because you always have to think about morbidity. And guess what? With estrogen stimulation, it will grow. So the answer is yes, they can grow back, and that is the reason, because estrogen feeds the fibroid. That is what makes the fibroid grow. So that's the first answer to your question. And I'm going to put a spin to it. When do I expect them to stop growing? When you get into menopause. Because when we get into menopause, our ovaries do not produce estrogen, or they produce it at a tiny, tiny low level. But generally, you can say we don't produce estrogen. In the absence of estrogen, fibroids don't grow. That is why in my postmenopausal women, I do not want to see their fibroids growing, because guess what? If the fibroids grow, then there's a problem. Now they're not behaving like fibroids. So that's your answer to question number 1. Now, question number 2. How do we decide whether we do a supracervical hysterectomy or a total hysterectomy? For the sake of our viewers, my sister, Reverend Pam, knows exactly what that means. But Reverend Pam, I am going to break it down for our viewers. History first. Again, we talk about the uterus. So if you look at it, this is the uterus, this is the cervix, and this is the uterus right here. The cervix is actually an anatomical component. So the cervix, you go through the cervix and you get into the uterus, right? So when Reverend Pam refers to supracervical hysterectomy, what she is saying is that the uterus was taken out, but the cervix was left in place. So you have the cervix, you go through the cervix, you get to the uterus. Supracervical, it just means above the cervix. So you take out the uterus, you leave the cervix in place. What my sister is referring to as a total hysterectomy is that we don't only take out the uterus, but we take out the cervix. So when do we make the decision as to one or the other? Generally, many, many years ago, when women had hysterectomy, everybody did a supracervical hysterectomy because of the notion that, some people thought that, it helped to prevent prolapse. We're not going to go into that a lot, but basically a relaxation of the pelvic floor organs. Some people felt that it preserved their sexual function. So many, many years ago, everybody did a supracervical hysterectomy. But guess what? Nowadays, there is no place for a supracervical hysterectomy unless in certain conditions. And I'm going to tell you why. What. So generally, the standard now is to do a total hysterectomy. Now, if I do a supracervical hysterectomy on a patient, I have a reason. Sometimes you always have to think of the safety of the patient. In some cases where it is unsafe, or you're going to increase the complication of surgery, if you have to take out the cervix, guess what? You need to leave the cervix in place because there is no need, and it is not very often that it happens. I'll give you an example. Sometimes when somebody has a baby, they deliver a baby, then they end up bleeding so much, postpartum hemorrhage, that we do everything to stop their bleeding, and it doesn't stop, and the only way is to take out their uterus. In circumstances like that, that's one of the times when I would consider I do a supracervical hysterectomy, because the morbidity is, because if you think about the pregnant uterus and everything that accompanies it, in situations like that, it is just safer. The patient is bleeding, you're trying to save her life. You don't have any business sitting there for that extra time trying to dissect out all the ligament, to dissect out the cervix. So in cases like that, you do a supracervical hysterectomy. There's certain cases where a patient might have a lot of adhesion and it becomes unsafe to take out the cervix. So you make a decision to do a supracervical hysterectomy, but the standard of care now is to do a total hysterectomy. Dr. Ogorje.
Can you repeat your last two questions, because I was on the phone when you...
Yeah. Okay.
I'm on call, so that's what happened. Okay.
Dr. Ogorje, I can tell you, I'm going to tell you, the other thing was about fertility. Reverend Pam is asking why sometimes in women with fibroid and some women with fibroid, some of them suffer from infertility and some don't.
Okay.
The first question has to do with food. Is there any food that can mitigate any of these two conditions?
Okay.
Or are there any food that can mitigate these conditions?
So infertility with fibroid, okay? If the fibroid is close to the horn of the uterus, what we call the angle of the uterus, it can block the opening of the fallopian tube. It causes infertility. If the fibroid is small and is located in the subserosal part, just beneath the endometrium, it might affect implantation. The woman will get pregnant, but it cannot implant. It causes infertility. Of course, the fibroid is huge, but outside, it doesn't affect the endometrium. It doesn't affect the condoom. The woman can get pregnant, but in pregnancy, they will miscarry because of the pressure. I've actually had women who got pregnant with big fibroid. At 20 weeks, they develop severe pain, and then they have to miscarry. And some women actually got pregnant with fibroid. Fibroid tend to grow, may grow in pregnancy. And when you grow in pregnancy, it can grow and grow and outgrow its blood supply and develop called necrosis. Necrosis is you cut off the blood supply, the cells dies. It causes severe pain in pregnancy that might go into preterm labor and the woman miscarry. So fibroid generally does not cause infertility unless it's located on the horn of the uterus or within the endometrial cavity on the subserosal area, or if it's so huge that the uterus cannot accommodate pregnancy. But if it's pedunculated, that means this is the uterus, there's a tiny bit of tissue and the fibroid is here, then that uterus will grow and push that away. Of course, the only problem is that as the uterus grow, that fibroid might twist and cause severe pain. Then you go and take it out. During my days of training, they said you should not touch a fibroid in pregnancy. Do not touch it, no matter how tempting it is. You might have a C-section, or it has a fibroid. Do a C-section and get out of there. Yeah. Do not touch it because of bleeding. Right. Of course, if the woman has a pedunculated fibroid that is twisting and causing pain, you have to do it. Right. If a woman has what we call the necrosis of the fibroid because of the size and the pain is so much, you tell the woman, I will go in to try and save your baby and take out the fibroid. If you survive, fine, it's a 50-50 chance of pain. So that's the answer to that. So position. Then the other one is food. All I know is that food rich in meat and beef predisposes to fibroid. Why food made up of fruit, vegetable and green leafy vegetables will reduce the chance of having fibroid. Again, we don't know why fibroids happen. These are just postulation that if you eat more red meat, you can develop it. Less red meat and more vegetables, the chance of having fibroid is smaller.
I agree. Sorry.
I need to go change in my scrub because they might call me anytime for.
You can deliver babies.
Don't go in your scrub and come back.
Hope the baby comes
my
quickly.
God.
You are animating this.
Wouldn't it be something if Dr. Ogorje has to live stream a delivery on this show?
I wouldn't want to be in
Top
the
of the hour,
theater.
we're the top of the hour, Reverend Pen.
Yes. Can you guys see my screen?
Yes.
Yes, we can.
Okay, we're gonna play our anthem before I give the announcement.
Oh, Africa.
How is the audio?
Oh,
Good. You
Good.
can put it louder.
Africans, Africans,
Okay.
Africans, Africans for Africa. Africans, Africans for Africa. Africans, Africans for Africa. Africans for Africa. Africans, Africans for Africa. Africans have many bright ideas. If only you let us share. If you really want to know my history, please come, sit down, listen to my story. God gave us a wisdom. He guides our footsteps, makes us shine and transform. Hey, as one people, with so many cultures, yet indeed we are one. Stand up, Africans, let's save Africa. Let us all unite behind Africa Online Media Corporation. Stand up, Africans, let's save Africa. It's time to come together, promote awareness, progress, and solution. Hey, Africans, Africans for Africa. Africans, Africans for Africa. Africans, Africans for Africa. All Africans can rally for a common cause, to believe without judgment in what our brother does, to identify and resolve our challenges, to allow each other's ideas without regard to standards. As one people with so many cultures, yes indeed we are one. Stand up, Africans, for Africa. Let us solve all the problems plaguing our continent. Stand up, Africans, let's save Africa. Let us empower Africans in and out of Africa. Stand up, Africans, for Africa. Africa Online Media Corporation, that's a good way to start. Stand up, Africans, let's save Africa. They have all the resources we need to benefit our society. Oh. Education for everyone. If we believe prosperity for Africans. If we believe medical facilitation for Africans. If we believe stand up, Africa, yes, for Africa. Africa Online Media Corporation, that's a good way to start. Stand up, Africans, let's save Africa. Africa is the cradle of civilization, the motherland. Stand up, Africans, for Africa. We were enslaved not because we were weak, but because of our hospitality. Stand up, Africans, Let's sing Africa. Jump on the Africa Online Miracle Jet. Don't be left behind. Stand up, Africans, for Africa. Together we shall succeed. Together we will win. Stand up, Africans. Let's sing Africa. We are writing our own story, the truth, and we shall tell it to the world. Stand up, Africans, for Africa. No more lies. Africans own Africa.
No more lies. Africans own Africa. Isn't that awesome? Isn't that awesome?
Yes.
Sure is.
You know, I would encourage everybody to hang around this show. We're going to have some major breaking news by the end of the show. I'm not going to give it away, but it is major. It's epic. The ambassador is so excited. I love this show. It's so unscripted, you know. But anyway, I am loving what our brother and sister are doing. Here comes Dr. Ogorje in his well donned from head to toe. The man is ready to welcome some new babies into this world. You know, next week or starting tomorrow, we're going to be talking about bereavement during this pandemic. You know, a lot of people and psychological distress. So we're going to have a psychologist, Dr. Nicholas Santos, who is our regular on this show. He's been on this show since the beginning anyway, Dr. Santos. You know, and he is just he's amazing. I'm just so excited because as I'm talking to you, there's something else. I'm so excited about this major breakthrough that's about to happen right now. In a few minutes, it's about to happen. So I'm multitasking. So just bear with me. You know, this we're going to be talking about a lot of people, not just Africans, have had loved ones pass away during this pandemic, and they were not able to be by their bedsides. Worst of all, we all know, we've done a show about elaborate funerals in Africa, and that has not been happening since the pandemic, and it has had a lot of psychological implications among our people. I'm telling you, in some countries, your loved one dies of COVID-19, they will actually confiscate the body and do it in a mass grave if you do not take them within 24 hours. So we're going to be talking about that. I am going to let the anchor speak because I'm getting distracted right now about this breaking news that's about to happen. So I'm going to hand back over to Madam President Ania Asong.
Sylvia, you go.
Go ahead. Oh, okay.
Oh, okay. All right. Okay, I'll go ahead then. Now, Dr. Nkuna and Dr. Ogorje, I have this general question about this inconvenience in our women. What should they do or not do when they are encountered with, or when they encounter these pains?
Well, you know, that's a very good question. I think that when you encounter this pain, like we talked about, we manage the symptom. The first thing is to seek care. You know, every time somebody has pain with their period, it's okay to take an NSAID, right? Like ibuprofen. And Dr. Ogorje actually was so kind enough to go on the chat box and listed some of their NSAIDs, right? Some of them you can get over the counter, some of them have to be prescribed. So the first management for dysmenorrhea, mind you, dysmenorrhea is pain with period, whether it's caused by endometriosis, whether it's caused by, you know, just prostaglandins that are part of the pathophysiology of menstruation, you can take NSAIDs. If that does not relieve your pain, you need to seek help with your gynecologist. If the nature of your periods change, it has to be evaluated, because guess what? You know, when there's an abnormality in your period, it has to be evaluated. It is not always because of fibroid, it could be something else. So it could be fibroid, but it might be something else, right? So you always have to seek evaluation, right? The other thing too, is that if you have pain outside your cycle, especially when they're consistent, you need to seek care, because one of the things that I want to drum home, there's a popular saying that all that wheezes is not asthma. You have to understand that the symptoms that we have discussed here today are not limited to endometriosis and fibroids. Sometimes people can have pain that is chronic. We call it chronic pelvic pain. Other things can cause chronic pelvic pain. So don't say Dr. Nukuna and Dr. Ogorje came and said, God, it is fibroid, it's endometriosis. We are saying that these are symptoms that present with this condition. So please, if you have chronic pelvic pain, you have to seek care, because there are other causes of chronic pelvic pain that are gynecologic in nature. There are other gynecologic things besides fibroid and endometriosis that cause chronic pelvic pain. And, some of which adenomyosis that Dr. Ogorje mentioned earlier. We're talking about pelvic inflammatory disease. We're talking about ovarian cysts, for instance. But there are also non-gynecologic causes of pelvic pain. Inflammatory bowel.
Happy birthday to you.
To name a few, interstitial cystitis.
Happy birthday to you.
Inflammatory bowel syndrome. So it is important to seek care if you have chronic pelvic pain. Answer to your question, yes,
Okay,
Thank you very much. Thank you very much. Yeah,
Ade, you need to wait. It's your birthday. This show is being interrupted because a skipper who is in Miami is about to sing happy birthday to Dr. Adeline Nukuna. She just reminded me.
We didn't know that.
What a blessing.
Happy birthday.
Happy birthday, dear Adeline. Happy birthday to you.
Yay, happy birthday.
Wow.
For she's a very good fellow. For she's a very good fellow. She's a very good fellow. Skipper singing from Miami.
Good job.
Hello,
That's
Doctor.
a treat.
Hello,
That's a
Dr.
treat.
Adeline.
Thank you.
I know I'm gonna see you next weekend in Delaware, so I'll bring your present.
I can't wait.
All right, Skipper, thank you so much. I just alerted him that it's your birthday, and that was a good cause to interrupt the show. So, Ade, you can continue. Thank you.
All right.
Bye.
Thank you,
everybody.
Bye.
But oh my goodness,
Yeah.
thank you. So I am going to use as part of my birthday to help all these women, or all our women who have all these problems, because this can cause a low for some women. But guess what? I am the possibility of helping these women to rise from their low to their glow. So let us continue. So just, there was another question about diet, and Dr. Ogorje shed some light on that. So sometimes with endometriosis, fruits and vegetables can help, and also omega-3 fatty acids have been shown to help. So I just wanted to bring that in there. The other thing that I really want to bring up so that we do not forget, is very important. Sometimes fibroids generally are benign. Uterine leiomyoma is a benign condition, but in some rare cases, fibroids can become cancer, and we call them leiomyosarcomas. How do we know? Because they don't behave like fibroids, right? So I'll give you an example. A fibroid that is growing at a very fast rate outside of pregnancy, like Dr. Ogorje said earlier, during pregnancy, because of the effect of hormones, your fibroids will grow. But outside of that, when fibroids start to behave abnormally, like they start to grow rapidly, we have to be concerned. When somebody is in menopause, right? Thank goodness for menopause, generally, the amount of estrogen produced is low. So what do I expect to happen to fibroids? I expect the fibroids to shrink because there's no estrogen feeding the fibroid. But if all of a sudden you're in menopause, and guess what? You suddenly develop fibroid that is enlarging, that is a problem. So we have to keep in mind that if you're in menopause and you suddenly feel like, God, my stomach my abdomen is getting bigger and I feel this pressure, don't just sit there and think, you know what, oh, it's just my fibroid. Guess what? If you're in menopause and that fibroid is getting bigger and enlarging, that's a problem, and it has to be addressed. So I just wanted to put those two things out there so that we don't forget.
Sylvia, okay, yeah, okay, yeah. Dr. Ogorje, go ahead. Dr. Ogorje, go ahead.
The idea is women with fibroid endometriosis need to discuss with their partners and say, hey, I have this problem, or let's go find what's going on. Women in Africa generally does not speak up. They do not speak up. So if they are listening, if you're having pain with your period or you're having discomfort in pelvic, speak up. go to your husband and say, hey, every time I have my period, it's so painful. What can we do? And hopefully, I'm hoping that the men too listening will say, okay, my wife have a problem. Let's go to the doctor and find out what's going on. There's always solution to these problems. The biggest problem with this thing is if you have infertility, that's a bigger one. But once you have all your babies, it can be fixed. If you don't have more children, birth control always help this condition. It's not always surgery. Surgery has a place, but not always surgery is the last resort. But speak up, have an honest conversation with your husband and say, I'm having this problem. Let's go talk to my doctor and see what we can do. So I can find out how to help you so you can live a normal life.
So Dr. Ogorje, from a man's perspective, I know Niason too is a man, but talking to you from a medical perspective, you know, our African men, I'm sorry to bring this topic, but hey, you're doctors, right? It's normally his way or no way when you're back home. He gets off and the woman is left, you know, hanging. So in this case where we have all these female issues, I'm going to call them female issues for a better choice of words with all due respect. How does an African woman tell her husband or whatever, lover, boyfriend, that these are issues? Because you African men are so quick, so quick. When the woman says, no, you're outside, you're looking for prostitutes. So how are we going to save our marriages in Africa for our women? Because when you're in pain, yes, you want your hubby all the time, it's true. But when the pain is there, you don't even want to think about that man in that way. But then the men are so not understanding us as African women. How can we circumvent this, or how can we deal with this in a way where nobody gets hurt? You know, at least it's a conducive, like sort of discussion.
Without deviating the conversation, Sylvia, without deviating the conversations, doctors, please hold on just a minute. When your tire gets flat, what do you do, Sylvia? Okay, the doctors, take. Don't let Sylvia answer. Don't let Sylvia answer. The doctors go ahead.
You are terrible. You are terrible.
God.
Again, that's what I said. I said an honest conversation. Most people, even with children, don't speak up in Africa.
Right.
My father says, this, is this or not this? My kids here, my son is only 11. He will tell me what he want to tell me in my eyes. That's it. My daughter will talk to me and say, Dad, this is why this. So I honestly believe that if we educate our women to speak up in a respectful manner, hopefully, because I say, hey, every month during my period, I have this pain, it's so painful, I don't know what's going on. Can we find a solution? I'm hoping and I'm believing that more than 80% of men will listen to their wife and find solution. I'm hoping and I believe that. On the other hand, if you don't speak up, how do you expect them to do? And don't wait until that time. You speak up. That's the training we have here. If you have a problem, discuss it. Discuss it and discuss it. Otherwise, there'll be problem. I've seen African men and couples who have problem with infertility. They raise it up gently and go try to find their solution before the extended family knows what's going on. And whatever you can do, get your man by your side and vice versa. If your man is by your side, nobody can come in there. That's all I would say. Speak up and be respectful about it, because African men don't like to be talked down.
Well, before Dr. Nukuna says something, I just want to say, as Reverend Pam likes to say, Asonglefac has been married for more than a decade, more than a century. And to tell you, Dr. Ogorje, you hit the nail on the head with the need for honest conversations. For all those centuries that have been married, we always had those conversations. And I think that is one of the reasons why I've never had a headache in my marriage. Dr. Nukuna, over to you.
Yeah, I have to say that I really appreciate what Dr. Ogorje and have said. I greatly appreciate that, because in every relationship, when it comes to health issues, be it gynecologic in nature or non-gynecologic in nature. I think both partners have to be open with each other. They have to communicate with each other honestly, and both of them have to try to understand the disease, because guess what? Sometimes illness, specifically in this case, fibroid and endometriosis, can affect your relationship in terms of the mental component that a lady goes through when in pain, the mental component that comes with infertility, if it gets to that, in terms of intimacy, sexual relation, it can affect even the intimate part of your relationship. So I totally agree with what our two gentlemen on this panel have said. Be open and be supportive of each other. Because when you're open and you understand the nature of this condition and any illness at large, you both can be able to find solutions. You both can be able to bring suggestions, because like I tell my patients, and I'm telling all our viewers and all our listeners, that you are the greatest proponent of your own healthcare. Make your partner a part of it, like Dr. Ogorje has very clearly stated.
Thank you, Dr. Adeline. I don't know if you have a copy of your book, From Low to Glow. Please get my brother-in-law to bring it really quick, because we have to promote that book on this show. Dr. Ajibade's hands are also, while you get my Moyo to bring your book, I'll hand the mic to Dr. Ajibade. She's been on from the beginning, and we have an Imani Brown. So Imani Brown, we are willing to give you the mic. I'll have to come back, but Dr. Ajibade, please unmute yourself and take the mic while Dr. Nukunago gets the copy of her book.
Thank you, Reverend Pam. Thank you to Dr. Adeline and Dr. Ogorje. Appreciate the conversation. I did say I had no comments earlier, but I decided I should share a little bit. And I'm gonna veer off, not off topic, but to another, I guess, another discussion related to the topic, because I had fibroids, actually. I do have 3 kids. And in my case, it didn't cause infertility. And my mother has 6 daughters. And I'm not the only one who's had fibroids. So definitely, I think there's, I don't know, maybe a family component, genetic aspect to this. I don't know if that was discussed when I wasn't online. But what I do want to ask them, I am a PhD scientist, so I definitely appreciate and I do my best to listen to medical expertise. But Dr. Ogorje brought up a very important topic about African women. Although I've lived here for 24 years, but especially relating to spirituality, right? I had my first child was breached and I had a C-section. Second child, we had moved from Texas to Illinois. So I told my doctor, I said, I want to have a VBAC. And they later found out I had fibroids actually when I had the first one. So she said, do you know fibroids can actually have caused the breached pregnancy? I said, I didn't know that, but I said, I'd like to try a VBAC, but I wasn't dilating. So I ended up having a second C-section. So when I was going to have my third child, I actually went to a family medicine doctor and who found a fibroid again. And this time, like you said, the cultural competency is key with we African women. I was really on a journey of faith that I would have a VBAC with my third child. And a lot of doctors would not even take on my case. I was praying a lot and believing that I would have the VBAC. My doctor found the fibroid and said, if this fibroid's still there, this is not going to happen. Well, I had the ultrasound, went back for another one, and the fibroid was gone. And I did end up having a VBAC. And the third child was born naturally, which I consider a medical miracle. So what I want to ask you, respecting, and I share that story cautiously because I've had 2 C-sections. I think at the end of the day, we want a healthy baby, right? No matter what. So I'm always very cautious to stress that we want a healthy baby. But have you experienced a medical miracle in this regard? Because I think, as people of faith, we should make room for that. Not that, we should be unreasonable or anything, and how that has impacted you at all.
Well, a couple of issues that you bring up that I want to address, and I'm glad you brought up those issues. You bring up pertinent issues. You talk about a VBAC, you talk about having had 2 C-sections, you talk about malpresentation of your fetus, and I want to address that because we don't have much time left. So I'm going to be quick. The first thing is that when somebody has fibroid, just having fibroid alone does not mean that you cannot have a vaginal delivery. It does not mean that you cannot do a VBAC. However, if you have had a myomectomy, if you've had removal of your fibroids where the cut, because most of the fibroids are located in that myometrium. When somebody has a myomectomy, which is removal of the fibroid from that uterine wall, what you do is that you are compromising the integrity of that wall. So having had a myomectomy is a absolute contraindication to a vaginal delivery, be it your first pregnancy, be it anything. Once you've had a myomectomy, please do not attempt a VBAC because it's a contraindication, because your uterus can rupture in labor because the uterus, the strand becomes compromised in very simple terms, and it can create a uterine rupture. So guess what? Any patient of mine with a myomectomy, again, remember that most of them are intramural in the wall of the uterus. That's it. The American College of OBGYN, that's an absolute contraindication. That's the first thing. The second thing that I want to talk about is about the VBAC. Many years ago, the American College of OBGYN, I'll call it ACOG for short, the recommendation was that anybody who had a previous C-section, right, and had only one C-section could attempt a VBAC, because we worry that the more C-sections you have, again, it compromises and you can have a uterine rupture. So many years ago, anybody who had one C-section could attempt a VBAC. The guidelines have changed. Anybody who has had 2 previous C-sections, as long as that C-section was what we call a low transverse, I'm not talking about the incision on your abdomen, I'm talking about the incision on your uterus. As long as it was a low transverse C-section, if you've had 2, you can attempt a VBAC. Anything more than 2, ACOG says no to a VBAC for safety reasons, right? That's the other thing. The third thing that you bring up is about malpresentation. Now, one of the things that we didn't get into were the risk of endometriosis and the risk of fibroid. Fibroid, and Dr. Ogorje kind of touched on this, by the way, because of fibroid, if you imagine that fibroid, like Dr. Ogorje said, some of them have a submucosal component. That can lead, one of the risks of uterine fibroid is malpresentation of the fetus. So you can end up with a breech presentation, right? Sometimes people can have preterm contraction. They can have preterm labor. Sometimes they can have preterm delivery, right? Sometimes it can also affect the growth of the fetus. So these are some of the obstetric complications of uterine leiomyoma. Now, the last point, talking about miracles, you know, I am a Catholic girl. I take my faith very seriously. I believe that God is our only power. God is my supply. God is my only power. Everything we do is done because of the grace that God has given us. And God is a God of miracles. So yes, in medicine, miracles do happen. I believe in miracles. Guess what? If I'm sick, I call God to heal me. So yes, there is definitely a place for miracles in medicine. Have I seen one? I cannot pretend that I have seen one. I have not, but I can tell you that there are stories of miracles, because ultimately it is by God's power.
I'm going to add something about the miracle, okay? Yes, I believe in miracle. You had a fibroid and it disappeared. What is the possibility of this miracle? During your last pregnancy, God help you. Your uterus grows so big that the blood supply to your fibroid cut off. It developed what called necrosis of the fibroid, and then it shrank and disappeared because it wasn't huge. If it's a big one, because as I said before, if you have fibroid in pregnancy, it tends to grow. It can outgrow a blood supply, and then necrosis is when there's no blood supply to that tissue. And if you don't have blood supply, what happens? It dies and shrinks and then goes away. Is it possible to have a small fibroid that the blood vessel that fibroid was cut off? It develops necrosis of that fibroid and then shrinks and disappears? Possible, I do not know. Does God come and take away the fibroid? Possible. So we can explain it medically and miraculously. We're all in the same place.
Dr. Adeline, can you, do you have the book now? The book information, we need to promote that.
Ladies and gentlemen, I am happy to show you guys a copy of From Low to Go.
Awesome.
Can you see that?
Yeah,
and,
so
I want
we get it?
And I want to bring some jealousy into it all.
Oh my God, yes,
I want to bring some jealousy. I want to bring some jealousy into it all, and to let you know that it is signed by the author.
Oh my God.
Beautiful.
That is the collaboration between Maryland and Delaware.
There you go.
How do we get the book? Dr. Ade, how do we get the book? How do our viewers get the book?
Well, you can either order it directly from me and I can mail it to you, or you can get it from Amazon.
Okay, if you need to get in touch with Dr. Adeline, send an email to info@africaonline.tv.org. She actually has an Africa Online email, which is the medical squad email, but I don't want to confuse our viewers. So send the email to info@africaonlinetv.org, and she will send you a copy of the book. So our anchors, if you guys can hear some, take a round. We need some last words. And let me welcome Imani. Imani, do you have just take a 20 seconds and just say something? Imani Brown, can you unmute yourself and just say something? Sorry, please unmute yourself.
Hello, everybody, and greetings on this call. I was invited by Ambassador Lisa Parks. I'm somewhat of her adopted niece. And I just think there was God that I ended up on here, even for the last few minutes. I'm trying to figure out what's going on with me now as far as some of the issues that I'm having. But yeah, I'm just grateful to be here, and I don't want to say too much because I know you're running out of time.
That's okay. Oh, nice to meet you, Amani, and hopefully we'll see you again. And I hope you can go back to Facebook and watch the whole show and listen to what our doctor said. Hopefully, yeah, some of your questions will be answered. But you are welcome.
All right, thank you. Appreciate it.
Thank you very much. And thank you, Dr. Ajibade, for your contribution. I was very touched by your story. Happily touched, not that sadly touched, but happily touched. So I'll turn first to Ambassador Lisa, your last word on the show.
Unmute yourself.
Unmute.
I'm sorry. I was busy trying to type on Facebook. This, as an adult woman who already has 3 grown children, I found it very, very interesting that I immediately got on Facebook and I started emailing all of my past in Africa saying, look, get your young women together, get your young men together. They need to watch this show because I'm very about how I educate and teach them, especially with the cultural differences. I'm an American woman going to Africa, and Africa, like Dr. Ogorje said, women don't speak up. They don't have a voice. They tell me things like, they're being told that sex is for men and it's their duty, so when they're having these issues and pains and things like that, I'm sitting over here in tears thinking, oh my God, how can I go back and fix this? So I'm encouraging everybody to watch this show. I've sent it to all my pastors individually, tell them to get your young people together, the husbands, the wives, and bring them together and get this information because it is so vital. Thank you so much, both of you. Awesome. Show, and hopefully we will do more these type of shows because I know for a fact that there's not a lot of doctor going. There's not a lot of visiting doctors in Africa. So things like this that give this basic information is definitely vital, and I appreciate you both.
Thank you very much, Dr. Ajibade. I know you are cheering us on, but you have a last word for this show. Dr. Ajibade, okay, there she comes.
Our professional expert speakers, I appreciate you. God bless you.
Thank you so much, Dr. Ogorje.
Well, we said it all. If you have fibroid or endometriosis or any type of pelvic pain or abnormal bleeding, please talk to your doctor and speak up with your partners if you have problems, if it's affecting your relationship.
Thank you very much, Dr. Ade Nukuna. You're welcome back to tell us your last word on the show before we wrap it up.
Well, I thank everybody for listening in today and for contributing. And please, you are your best health proponent. So pay attention to your health, go to your doctor, seek medical care if you have any of the symptoms that we have discussed on this show.
Sylvia?
Wow, outstanding. I'm in my language, we say I'm mouthless, meaning I'm speechless. What I have learned today is an eye-opener, and I'm a mother of 4 daughters. So I have really grasped quite a bit of this. And this is one video, or one show actually, like Sister Lisa said, that I have to keep from my archives because I'm always ministering to the young ladies of today. And this is something that they have to hear, like we say, quote unquote, from the horse's mouth. Doctors, you did an outstanding job. Thank you so very much for this invaluable.
Thank you very much. Thank you very much. And over now to Reverend Pam.
Yeah, Dr. Ade and Dr. Ogorje, this Zambian woman is never speechless. So you guys did a marvelous job to render her speechless, but I am so proud of you. And again, you guys are evidence that we are doing right. This show is actually 5 years old. You know, the organization will be 5 years old in June, but this particular show is 5 years old. And I just want to say, I don't really need to thank you guys on behalf of the organization because you are part of the organization. So you guys are doing your duty. And God is definitely going to bless you guys. I love this tag team. So anytime we have women issues, I think we should bring this, our brother and our sister, back together. What do you guys think?
Amen.
They did a
They
phenomenal
did a great job.
and it was unscripted. That's the
Yes, I like this combo.
the main thing about it. And Dr. Ade, I'll be seeing you on a family Zoom in the next 30 minutes. Happy birthday. I wish I could sing like you.
Happy birthday, doctor.
Yeah, you have a beautiful voice. But just one quick thing I want to say to our women out there. Please, you know, if you are having severe problems, God is not against medicine. St. Luke was a physician. If you have to get your organs out, please take it out. Don't suffer pain. And for the men, if your wife cannot have sex with you because she's having pain or menstrual cramps, instead of going out there to chase another woman, lay next to her and massage her abdomen and sing to her and take care of her, and that pain will go.
Thank you all so much. Thank you all for participating. I learned one thing today, UAE, I thought it was United Arab Emirates, but I realized that it's a medical term also, a medical abbreviation. I thank you, Dr. Nukuna. I thank you, Dr. Ogorje. I thank you, Dr. Ajibade. I thank you, Imani. I thank you. What's his name again? I always forget his name. He sings for us every day, but I forget his name all the time. Yeah. Skipper. Thank you, Skipper.
And you better thank me.
Ambassador Lisa, thank you very much. And thank you for all the posts that you do. We appreciate everything. This has been Africa Online Media Corporation, bringing you the topic that we just finished discussing. Look out for the next topic.
So you did not thank me. That's discrimination. You did not thank me.
Oh, thank you, Chair. Thank you, Chair, for always being there and making sure that this show goes spotless. Thank you very much.
Oh, wait.
Week.
Bye.